famine in some part of India or some part of the world. Famine has disappeared. When I was a kid reading newspapers, every day there was some news about famine in some part of India or some part of Africa or some part of the world. Why famine has disappeared? It's because price of food came down by 83% in the last 100 years. And all of us think that it has happened naturally. It didn't happen naturally. The people involved in food production, distribution, and selling, they innovated every aspect of producing food and delivering food. The entire revolution started with the grocery store in, I think, Tampa in US in 1918 called Piggly Wiggly, which introduced the concept of aisles where you could go to the grocery store and buy everything yourself. And that is how the revolution started. But unfortunately, such a revolution has not started in any part of the world in delivering healthcare. We deliver healthcare exactly how we did 70, 100 years ago. Hospitals have never changed, never involved in any innovation. But things are going to change very, very rapidly, especially in India. India is known for its unique qualities of making things affordable to everyone. 30 years ago, when I was just beginning my practice 36 years ago, I came back from England and I was predominantly treating working class and poor families. I could clearly distinguish between a person who can pay, that's a rich man, from a poor man, by the way the clothes he was wearing. Today, I can't differentiate between the rich and the poor by the clothes they are wearing. So it is difficult because everyone pretends to be poor because they don't want to pay for the treatment. So I lost one of the important identifiers. Then gradually the mobile phone came and I used to differentiate when a person says poor, I used to see whether they have a mobile phone in their pocket. And people who have the mobile phone, I thought they can afford to pay for the healthcare. Now, that indicator is also gone because even poor people have, the poor people have mobile phones. But these are feature phones. Then I started looking at the smartphones. If somebody has a smartphone, he's a rich man. Somebody has a feature phone, he's a poor man. That also is gone. Today, everyone has the smartphone. Then I started asking them, sitting in Bangalore, how did you come to Bangalore from Calcutta? How long it took you? Because I wanted to see whether they flew or came by train to know who can afford to pay. Now that is also gone, even poor people can fly. This is a very interesting country where we make everything affordable to the common man in a remarkably short period of time. We run a hospital in Cayman Island, which is considered as one of the richest countries in the world. Significant percentage of the population living in Cayman Island do not have data in their phone because they cannot afford it. In India, even the beggars have data in their phone. They can watch any movies what they want. Indians sitting in a slum, they access Netflix and Amazon programs at a throwaway price. And I believe the same revolution will happen in healthcare. We believe that India will become the first country in the world to dissociate healthcare from affluence. India will prove to the world that the wealth of the nation or wealth of the family has nothing to do with the quality of healthcare its citizens will enjoy. And that is not going to take 30 years, 50 years to happen. It will happen within the next 5 to 10 years. Why all this transformation will happen? This transformation will happen because of many policy shifts and the perceptions. Since independence, we have heard all our political leaders saying that it is a duty of the government to offer healthcare to all the citizens free of cost with the taxpayers' money. Universal healthcare for free. And that slogan started since independence. Unfortunately, it continued for a long time, and that was the right thing to do. But we analyzed the countries which have successfully implemented universal healthcare for free with the taxpayers' money. There are 3 things common with these countries. First thing is, all these countries are small countries with a population of 500,000, 1 million, 2 billion. The moment the population exceeds 20 million, they always have a problem. England, with a population of 60 million, is struggling to offer the healthcare to the citizens. No large country in the world, including United States of America, today can offer healthcare to the citizens free of cost with the taxpayers' money. It has not happened anywhere, so there is no point in we expecting India to do it. Second thing, what is common with them is all these countries have a very high tax to GDP ratio of 25% to 45%. India, with a tax to GDP ratio of 11.2 or 11.5%, cannot dream of offering healthcare to the citizens with the taxpayers' money. Third common thing with all these countries today spend more than 10% to 20%, 18% of the GDP on healthcare today. Our country is spending hardly 1.52% of the GDP on healthcare. Now, to increase it to 10%, it is going to be virtually impossible for a country of our size. So, when the global learning is against this concept of offering free healthcare to the citizens with the taxpayers' money, there is no point in we trying to prove that we are right and the rest of them are wrong. That is the most important fundamental truth about healthcare delivery. Now, what is the fundamental flaw in the approach of policymakers, not only in India, all over the world? The fundamental flaw is that I have gone through the policy documents of most of the developing countries. The policy documents on healthcare, most of the countries, are always talking about malaria, TB, and HIV. Malaria, TB, and HIV annually kills about 1.3 million people. But lack of access to safe surgery kills 17 to 18 million people every year. Now, when I talk about surgery, I am not talking about a heart surgery and brain surgery. I am talking about access to simple surgeries, what we call as bellwether surgeries. Surgery for cesarean section for obstructed delivery. That is, a young lady is giving birth to the baby and the baby is stuck. The mother requires emergency cesarean section. This is one important surgery. Surgery for burst appendix. Patient had appendicitis and the patient was not treated. the appendix burst, it requires a simple operation. And the third thing is any fracture where the bone is exposed. If these three surgeries are made available to the common man, nearly 32% of the deaths could have been prevented. So, our policies are not talking about the surgery. Unfortunately, the money spent by the policymakers on malaria, TB and HIV cannot do the surgeries. But if the surgery is available and made available with a good infrastructure, that infrastructure can take care of malaria, TB and HIV virtually free. It is a matter of what is a priority, national priority. So this is where we have to invest. Now, surgery is a problem because when the person requires a surgery, they need money upfront. Whether it's a medical treatment, they can gradually spend over a period of few days to few months to few years. So, if we want to transform healthcare in India, surgery should be available to everyone. And the best way is health insurance. Thanks to the newly reconstituted IRDA, which was reconstituted about 3-4 years ago, with very dynamic people, today organizations like hospital like ours have become a health insurance company. Now, first of all, why hospitals should become health insurance company? When there are big insurance companies which are already offering health insurance. Unfortunately, the health insurance delivery model in India hasn't succeeded in delivering what is expected to do. In healthcare delivery today, there are three important stakeholders. There is hospital, there is health insurance company, and there is patient. Hospitals do not trust the health insurance company. Health insurance companies do not trust the hospitals. And the patient doesn't trust both parties. And those two parties don't trust the patient. So we have three important stakeholders in delivering healthcare who do not trust each other. In any field, if there are three important stakeholders who do not trust each other, that business cannot be scaled up. Now, why hospital will be successful? The reason is, I'll give you one example. We run a chain of hospitals. About 16% of the heart surgery done in India is done by our group across the country. More people develop heart attack, it is better for my business. I have absolutely no incentive to prevent people from developing the heart attack. Whereas when I become a health insurance company, I will work very hard to make sure that nobody develops heart attack and nobody falls sick. When that happens, it is good for the customer and it is good for me. Today, sitting in this chair, when I see a patient, I tell the patient that you need a bypass grafting. First thing what goes to the patient's mind is it really required? Or this man wants to make money out of me. So when I become a health insurance company, and I tell my customer or patient that you need a bypass grafting, there is no suspicion, there is no conflict because I am going to pay for it. Then patient's interest, my interest is aligned. Then that business will flourish. We have a dream that in India, there are essentially about 250 million families. First 100 million families can afford virtually anything in healthcare. They don't need any financial help. Second 100 million families generally work in the organizations created by the first 100 million families, or they work directly under them either in their house or either in their small factory or somewhere. And this 100 million middle class, so-called missing middle, they cannot afford the high cost of healthcare, but they can afford an affordable health insurance. Now, what is an affordable health insurance? We believe that a family made up of the father, mother, and children, if we can offer a health insurance, which will cover them for all types of operation, including heart transplant or artificial heart or a liver transplant or a multiple organ transplant. So we would like the missing middle families to be covered for any type of surgeries to the tune of 1 crore rupees. Now, but what should be the premium? We believe with great difficulty, they can arrange for 10,000 rupees premium, which will cover them up to 1 crore rupees. 10,000 rupees is quite a lot of money, but a family which earns about 20,000 rupees per month to 60,000 rupees, the so-called missing middle, with some difficulty, we can or they can buy this health insurance. That is why we have launched an insurance for this category of people. Now, how did we come up with 10,000 rupees is the amount of money this missing middle can afford to pay? This is based on our daily experience in dealing with this category of people. A typical patient of mine is a little kid sitting on the mother's lap. I examine the kid and I tell the mother that your baby has a hole in the heart and he requires an open heart surgery. She has only one question. The question is how much it is going to cost. She will never ask me the scar or how many days it will take for the kid to be in the ICU. She has only one question: how much is it going to cost? And if I tell her that it is going to cost maybe 3 lakh rupees, which she doesn't have, that is a price tag on the kid's life. You come up with 3 lakh rupees, you can save the child. You don't have 3 lakh rupees, you are going to lose the child. This is what I do from morning till evening, putting price tag on human life. This is what every doctor in all the developing countries do, from morning till evening, putting price tag on human life. But there is a twist to this story. The twist is, this lady, when this discussion goes on, she will touch my feet, she will cry, she will beg. It is a very humiliating experience we doctors go through every day. But in the end, most of them, before they leave my office, they will turn around and say that Ami 1 lakh dete pare, I can give you 1 lakh rupees. That made us to think that a lady coming virtually from a slum to save her child's life today has the money to pay us 1 lakh rupees to save her child's life. So if we have a health insurance to cover her family for any type of surgeries for 10,000 rupees, this lady today has enough money to pay the premium for surgeries for the next 10 years. But I didn't have the insurance to offer to her. So today, thanks to IRDA, which has allowed organizations like ours to become a health insurance company, we are offering that health insurance. So this is going to be a game changer because Indians cannot afford cost of healthcare, but they can afford the cost of affordable health insurance. This is going to dramatically change the way healthcare is delivered. We always think that a lot of things happen in China and they are far ahead of us in everything. But very interestingly, that is not the way in reality it happens, at least in healthcare. I will give you one example. All of you are very educated, smart people, mainly dealing with finance. I'll ask you one question. How many cataract surgeries are done in US, in China, and in India? You'll be surprised with the data. US does 3.5 million cataract surgeries a year. China, which is maybe 4 times or 5 times bigger than US, does 3.2 million cataract surgeries a year. Now, how many surgeries, cataracts are done in India? India does 8.5 million cataract surgeries a year. India does more cataract surgery than US, China, and most of the European countries put together. And it is a very sophisticated operation. How did this happen? All this happened because of the change in the business model of delivering eye surgery. First thing, 25 years ago, ophthalmologists decided that we will get out of the hospital. Because in the hospital, there is no way we can give personalized care and there is no way we can reduce our cost. They went out, they rented one house, the ground floor of the house, they used it like their clinic and the operation theater. They lived on the first floor of the house. Whenever they had an eye surgery, cataract surgery, their wives or the spouse assisted them, and this is how they reduced the cost and made it affordable. And this is the way healthcare will deliver. We cannot say that patients have to come to the hospital for anything and everything in healthcare. Everything else has reached home or nearest to the home. Healthcare has to happen. So we have taken the first step in the direction. We would like preventive care to be available to every person close to their workplace or close to their house. Why we have invested heavily in creating a preventive health checkup system in a tech park in Bangalore, where there are about 65,000 people work. So we have created a setup only for them with all the advanced equipments, including CT scans. It is far, far away from my hospital. Why we have done it? We have done it because I live in Bangalore, which is one of the most educated city in the country. In Bangalore today, there are few thousand young ladies in their 40s or early 50s who are very active, who have no symptoms, but they have an early stage breast cancer. They will never go for a preventive checkup. And in a year's time, the breast cancer becomes inoperable. If we diagnose it today with a small operation virtually under local anesthesia, we can cure them. In Bangalore today, there are few thousand 30-year-old, 40-year-old fit people, men, with very advanced coronary artery disease, but they have no symptoms. They have no pain. They will never go for a preventive checkup. But if they start running on a treadmill or a marathon, they will drop down dead. And that becomes a news. If these people went for a preventive checkup, all these problems could have been detected and all these needless deaths could have been prevented. Why it doesn't happen? It doesn't happen because people don't know that how fit they feel has nothing to do with how fit they are. If you tell me that you climbed Mount Everest twice in a month and you are a fit person, I can only congratulate you, but I will never certify that you are a fit person. To certify that you are a fit person, I need to know your blood profile. I want to see the ECG, I want to see your echocardiogram and ultrasound, those basic tests. And these tests are available predominantly in the hospitals. And this is a place where fit people will never go for the preventive checkup. So we thought we'll create this facility in a tech park, assuming that people will come and utilize it. So hopefully it should happen and the people will embrace these the modalities of healthcare, and large number of people with the pre-existing disease will be diagnosed. The other important observation I have is that entire healthcare will move on a digital platform. Everyone must have their medical records in their own mobile phone, especially the people with a pre-existing disease. Large number of people come to our hospital with this thick file, and doctors don't have more than 5 to 10 minutes to decipher all your papers. If it is in a digital format and one sheet of paper gives you all your salient features of your illnesses, whatever you have, in no time doctor will know the status of your health, and you don't need to go to the clinic. You can send your papers online to the doctor. Doctor can see you online and he can advise you. It is very, very important for you to have your medical records, especially your ECG if you're a heart patient, and the blood test reports, because today everyone is traveling and all you know, you're in a hotel room, 2 o'clock at night, you get chest pain or you're unwell. If you are having all your medical records, lot of unnecessary tests will be avoided. Lot of unnecessary treatment will be avoided, which can have potentially dangerous consequences. Like if you had a heart attack in the past, your ECG will always show you had an attack. But you land in the hospital without a ECG, they will do a fresh ECG, look at the change, and they will think it's a new heart attack. And they can give you some medicine which can be fatal. So it is very important that everyone carries their medical records in their own phone. Why phone? Because medical records should be with you always, wherever you are. Today people forget their spouse, but they never forget their mobile phone. So we would like you to have your details in your own mobile phone. So I think I have spoken enough, and I'm happy to, if you have any questions, I'm very happy to answer.
I have a question, sir.
Sure.
Thank you very much.
Can I ask, sir?
Yeah, please,
yes,
Professor
please.
Jayamar, go ahead. Yeah.
I think we have emphasized on one important point of hospitals becoming insurance companies as well. Is this particularly at this your institute, or is it becoming a national phenomenon? Because these are two different businesses. So combining them, the skills required are different. So what are the challenges involved in combining? Second, in the digitalization is extremely important for health, but in India the progress is very small. Only during the COVID time there was more for this digitalization, but now again you go and consult the doctor, you have to carry your file. I go to a cardiologist, I have to take my file. I go to a diabetologist, I have to take my file. I go to a urologist, I take my. So how you bring transformation in the country using the digitalization? Thank you, sir.
Thank you.
Dr.
The,
Shetty, that was Professor J. Reddy, the previous Vice Chancellor here in the Institute. Yeah.
Sure.
Go ahead.
Yeah, can I answer?
Please.
Yes. The hospital we are the first hospital group in India to take up this route, and God willing, if we succeed, we feel many more hospitals will follow. Why hospitals should become a health insurance company? The policy today everyone has in health insurance pays for the treatment when the patient is admitted to the hospital. It's just a financial intermediary. But a health insurance company should become a custodian of your health care. We should conduct a detailed evaluation of your health every year by preventive checkup. And if you have a high pressure, and all the primary care should be offered by this entity. All these services can be offered only by the hospital because all these facilities are available to us, whereas a health insurance company has to borrow these services from the hospital. Then it becomes unviable. India is the only country where health insurance companies pays only for this treatment in the hospital. They have nothing to do with the outpatient costs. So the health insurance has to change, and it should become very, the health insurance company should be involved as a custodian of healthcare. That can only happen if the hospitals are involved. That is about the health insurance, why hospitals should become health insurance companies. The second thing about technology, 67% of the sentinel events, first of all, everyone thinks that the hospitals are safe places for the patients. Hospitals are not safe for the patients. Let's look at American hospitals, which are considered as some of the safest hospitals in the world. If 200 patients get admitted to an American hospital, 1 in 200 dies due to medical error, not medical negligence. Getting admitted to an American hospital is 10 times riskier than skydiving. Now, why the medical error happens? According to Joint Commission of US, 67% of the sentinel events happening in the hospital, which generally leads to the death of the patient, is due to communication failure. Communication failure happens because most of the hospital, nearly 80% of the hospitals across the world do not have electronic medical records. All the transaction happens in paper. So the blood test report shows deadly bacteria, but the report doesn't reach the responsible doctor whole night, and in the morning when the report comes, it is too late. Whereas a digital format will address this. And the second problem is, even in the developed country like US, these electronic medical records are developed for the desktop. Doctors look at the desktop 5 to 6 times in a day, but they look at the mobile phone 200 times in a day. So our software engineers, when they create this digital platform, they embrace the mobile first approach so that doctors, wherever they are, they're able to access the data of their patients. So India will dramatically change how the digital platform of healthcare is built, and this will be available to most of the hospitals in India because we are blessed with brilliant software engineers who can make amazing products. Thanks.
Thank you, sir. It was an excellent presentation. Thank you, sir.
Okay, can I ask you a question, sir?
Sure.
Yeah, ORS,
So
please.
this is for Professor O.R.S. Rao. I'm the Chancellor for one of the universities in Sikkim. Sir, as you rightly put it, currently the health insurance covers only the hospitalization charges. Whereas what we have been seeing in the last few years, and particularly during the COVID time, was the costs of medicines have been sort of going so fast, they are at least twice or thrice the inflation rates. So maybe the government of India tried its best to get into the generics. But as we have seen, it hasn't made that much of headway. And I request your views on what is the way to move forward. On one hand, in India, we are not, into the kind of drug discovery in any way so far. It's all the kind of regime of the kind of Western countries, and wherein, with the result, the most kind of, the advanced medicines we can't get it here unless you pay for that. The second query that I have to you is, today the artificial intelligence is making waves. What are your views, on how the AI is going to impact the healthcare in India, both in terms of quality and making it affordable for the common man? These are the two things.
Sure. First of all, a health insurance entity must take care about any household, their expense for the healthcare for the year. Only 40% of it is used inside the hospital. 60% of the national expenditure on healthcare is spent outside the hospital. 60%. And that is where they need the help. Now, a hospital like ours, organizing primary care for our insurance members is not difficult because we have started creating multiple clinics. And contrary to the popular perception about the high cost of medicine, India is the pharmacy of the world, and medicines are the cheapest in India. Only some of the branded drugs are expensive, which are protected by the patent rights, but even they are significantly less expensive. Now, when the medicine reaches the patient, it would have changed hands 3-4 times, and each one adding 20% is adding significantly to the cost. Whereas as a hospital, we can procure directly from the primary distributor or from the company itself and give it to the patients at a significantly discounted price. So essentially, when the hospital becomes the custodian of healthcare, lot of middlemen involved in the whole delivery channel will be addressed. And more than that, once we have your medical records, we really don't need to see you every time you have a problem. Because if you tap on our app, 2 o'clock at night, first our nurse will come online, then our doctor will come online, and doctor will say that, look, I have gone through all your reports. You had a detailed checkup only 8 months ago. Your heart is fine, there is your echo, ultrasound, everything is okay. And then whatever medicine is required, we will be able to provide it. And if the patient doesn't get better in 2 days' time, the nurse will keep monitoring. Lot of things can be simplified, and lot of unnecessary expenses will be avoided, especially for the missing middle families. Because in a missing middle family, if somebody has a high fever, they go to the doctors and a small nursing home will invariably ask them to get admitted. They put up a drip. The patient stays in the hospital with the drip for 2 days. They spend 2,000, 3,000 rupees, which is really not required. All they need is a medicine for the fever, and within 3-4 days they will get better. So we believe that when the hospital becomes the custodian of healthcare, lot of problems of the patient can be addressed, lot of diseases can be diagnosed at an early stage, and when you diagnose the disease at an early stage, most of the diseases can be cured. Even if you can't cure them, you can give them meaningful life. Thank you.
You shared, at least to me, Dr. Shetty. One is, you're not really as fit as you think you are, or as you may feel. Now, that's quite an eye-opener, I'm sure, for many of us in the audience here. We may feel we are okay, but in reality, we may not be okay. So this kind of self-deception could be quite deadly for many people, actually. The other thing you talked about is that our focus on diseases rather than the treatment, like surgery, if the focus shifts, we could actually lower healthcare costs quite significantly, Total, I mean the macro costs for the economy itself. Those were two very big lessons. There are any questions from the audience here? Please do ask, because it's a good occasion for us. And I think we can learn a lot about healthcare, costs, spending, hospitals, prevention. Maybe I'll help with a starting question. Is there a way in which hospitals could have an investment budget towards preventive healthcare?
You see, it's very interesting. That I talked to you about us setting up a preventive checkup pilot in a tech park. And this project, in this tech park, what is unique about this place is we have changed the stream, the way the entire checkup happens. We do detailed evaluation starting from blood test to carotid Doppler, echocardiogram, ultrasound, CT scan, every mammogram, pap smear, everything is done. And all the tests, if it is done in a hospital, my hospital, it will cost about 28,000 to 30,000 rupees. And at the tech park, we are going to charge them 4,500 or 4,000 odd rupees. Now, then it will take whole day for all these tests. We are promising the customers that we will do it within 60 minutes. And if we exceed 90 minutes, we'll return the money. Right? So essentially, if you change the way the healthcare is delivered, amazing things can happen. But then we should be able to experiment, try, and sometimes we fail, but we have learned a lesson. We believe that healthcare will go out of the hospital to the community, and that is the only way utilization of healthcare services will become more. So more and more diseases will be diagnosed at an early stage. Now, in good old days, there was when you talk about the preventive checkup, cost was formidable. And because of the cost, it didn't become a standard practice in medical practice to get all these tests done on people who have no symptoms. But today, we are in a position to reduce the cost. Now, how can the cost go down from 30,000 to 4,500 rupees? I will give you one example. A CT scan can cost between 6 crore to 8 crore rupees. And average number of CT scan done per machine in India in every hospital is about 5 to 10 or 15. But this machine can do nearly 250 CT scans per day. Now, why this is not happening in the hospital? because hospital don't get that many patients, first. And the way the hospital runs, you cannot increase the number because hospital treats large number of sick patients with diverse problems. So the study type is different, whereas in a diagnostic lab, it is different. So once you change the way of delivering healthcare, cost will go down and people will diagnose a problem, get the diagnosis at an early stage.
Thank you very much, sir. Sir, do you also have some kind of a systems and process research group associated with your hospital to look at the economics of healthcare at the micro and the macro level? I mean, it's more an institutional question I'm asking because, out of curiosity. Yeah.
Can you kindly repeat the question? I'm not.
You are running a large healthcare institution. By any chance, do you have a research group that studies the systems and process from an economic angle, the micro and the macro side of healthcare, providing healthcare? Yeah.
We have very active research department in clinical research mainly, and a huge number of, but economic study, no. We'll be delighted to welcome anybody who wants to do the study.
Great.
And we would love to guide them. Yes.
Thank you very much, sir. Anybody from the audience, please? Yeah. Yeah, I think Dr. Saumit, yeah, please. Yeah, please use the mic, yeah.
Yeah, good afternoon, sir. Thanks for giving such a wonderful presentation. I'm Dr. Saumit from FST ICFAI. Sir, I have a very fundamental question. We do talk a lot about buying health insurances as well, and you talk that hospitals are those days working as insurance companies to do so. So why not, instead of buying insurances, the hospital should collaboratively make policies with the governments, particularly the health sector of a state or a country, to improve the standard of living of common people? Because most of the time what's happening is the health sector is seeing that the degradation in the health is due to the poor living of standard of the common people. That's why the major diseases are happening. So instead of collaborating with the insurance companies who will be providing the insurance benefits, why not there are policies being made by those health institutes with the health sectors of the government so that the living of the common people can be increased or can be improved, sir?
It is not either or. We need to do both. It is very important that the living standards of the people should get better, that there should be better water supply, better air quality. All these things have to be done. Along with that, we also have to do this part. Yeah, both are required. Both are required with equal importance.
Anyone else, please?
Hello, sir. My name is Aruna Reddy. I am a professor in ICFAI School of Architecture. I have a statement, maybe like my opinion. I won't agree that the healthcare in India is free, even if it is a government hospital, because as a society we all pay for it, and most of us work. It's not only about the middle class educated people, even the poor people work hard, and they do actually contribute to the Indian economy, and maybe we are not recognizing them as much as we are supposed to do. So they are paying for it, and even though they're not paying the taxes directly, through the work and through the economy, they are paying for the taxes also. So I won't agree that it is free. Sorry if I don't agree with you. And the second question is about the insurance. Is there a possibility, of course all the doctors, they do take an oath that they do serve all the people who are coming to their door. But it is not necessary that all doctors are next to God. There is a possibility of commercialization can involve, once you say there is an insurance involved. What is the possibility that the patient who comes to them, there is they do get the service because they're paying for it in beforehand, and to save the money they can get them, they can be misled. So that is my question. Thank you.
It's not very audible for me. Can somebody repeat the question in a nutshell, please?
The first part I can, sir, if you are able to hear me clearly.
Yes.
Technically, we would not like to call healthcare as being free because there is an indirect payment via various means, taxes, etc., which goes into the economic costs of running a hospital or an institution, even a public hospital or an institution. So technically it's not free, but I think the point is, you probably refer to the point of transaction being free. You know, at that point it perhaps is free, but there is a larger system working. The second one I couldn't get exactly, Aruna. It had something to do with the insurance part actually, and the prior knowledge of the payment of insurance. Am I right? I couldn't get the exact question though, Aruna, please.
Sure.
Yeah.
The answering the free healthcare, in most of the Scandinavian countries and European countries, whether it's in England, where I used to serve the National Health Service, we have massive hospitals, but there is no cash counter in those hospitals because no one pays. In India, at least there are some cash counters in the private hospital, in the government hospitals for some registration. But NHS, most of the hospitals in Europe really don't have a cash counter. And that is free. That is free to the patient. Of course, there is a huge cost involved in delivering healthcare. Yeah.
Aruna, the
Thanks.
second part? Yeah, please.
The second part is about the, maybe I don't know if I should say that. What if the doctors, like if they don't follow the oath and they become selfish and eat up the money?
Yeah.
Directly saying.
She is talking of the violation of ethics in medical practice,
Yes.
driven by commercial considerations. Yeah.
See, in every profession, there are good people, many good people and few bad people, and medical profession is not an exception. It is sad when that happens, but fortunately that number is very small. But in every profession there are people who exploit their customers. Yes, I agree.
Yeah. Thank you very much, sir. I think we have reached time. Thank you for sharing your insights based on your knowledge and experiences. And thank you for the audience also for having been here. And I hope we benefited a lot by listening to the lecture by Dr. Devi Prasad Shetty. So may I now request Professor Rangarajan to share his presidential address here. See there? Dr. Rangarajan.
Thank you very much. Certainly it has been a very exciting and entertaining learning process this evening. Dr. Devi Prasad Shetty is quite well known in the country. Many people have known about the very many experiments that he had done and many innovations that he has introduced. When I first saw the title of the lecture, it was all about digital health, and I thought it was we are going to get a whole lot of things on digital health. But fortunately, he opened up and he has really talked about a number of issues which we need to bear in mind if we really want to make the healthcare in India affordable, available, and in many ways, it is comfortable to most of the people. Will this be possible? He raised this issue of insurance. He also talked about the fact that most people in India think in terms of medical care, health care being provided by the government. This is something to be expected because we have gone through a long journey from the time of independence, when our per capita income was much low. In a situation like this, to expect the government to fulfill some of the basic needs was always regarded as essential and a prerequisite for a good governance. Therefore, it should not come as a surprise that India expected it, and many other countries also went on the same track. Now, whether insurance by itself a solution to this problem, or is it some combination of that which is really most appropriate? The question is that even the kind of premium that he talked about may be beyond the affordability of several people. Therefore, in some sense, we really have to go with a scheme in which the government has an important role to play, and where provision of certain types of facilities at least must be provided free. But there may be other sections of the population which can be treated or it can be taken care of, whose health care will be probably be taken care of through an insurance system. It is not an issue into which I have gone into before, but certainly I think the need for differentiating certain kinds of people from certain others in terms of affordability becomes important. Let us also remember one other thing, that insurance is based on the principle that the probability of the event occurring, whatever may be the event, has a certain probability which is not 100%. Therefore, in the case of health care and health insurance, there is always a problem unless the insurer excludes something. Otherwise, every person is going to have some problem or the other, and he really requires to be taken care of. Therefore, the probability calculation, which is implicit in all insurance contracts, has to be looked into carefully. And I would say that it is not the responsibility of the government to take care of all people, underline the word all. But it is the responsibility of the government to take care of certain categories of people. He himself pointed out in the course of his observations that even insurance need not cover all kinds of mishaps that might happen. We can restrict only certain kinds and allow them to be covered. Therefore, the issue is not, in my opinion, that the government, whether the government has a responsibility or not. There is a responsibility which the government must bear, and it can be taken care of in a number of ways. And lots of commissions and lots of committees have reported on how the primary health center should be handled, how the tertiary, the secondary should be handled, and so on. And in fact, a lot of people have been writing about the need for emphasizing the primary health center a lot more, and because that is nearest to the home, nearest to the patient. And this kind of health care may be, in fact, more urgent in the rural areas than in the urban areas. And a lot of people have written about how this primary health center system, as we now call, can be improved. Obviously, there are many things that can be done in order to make the field also comfortable to the kind of treatment given by the government hospitals or government health centers and so on. Therefore, I would say that the lecture is an eye-opener in the sense that where really the focus should be now in the light of the developments that are happening. I will say a few words about digital health because the digital health is also related to many other activities that are happening in India and elsewhere, and the importance of informatics or the information technology feeding into the more efficient functioning or the efficient performance of that particular activity. But as I said, at the primary health center and the need to look at the institutions at the base was really thrown up during the COVID period. The COVID period showed our shortfalls in the physical infrastructure, in the case of human infrastructure, and so on. We never thought that we were so much lacking. And apart from the nature of the pandemic or the epidemic, the fact that we could not even get oxygen for all the people required, all this clearly indicated that the health system that we now have needs to be improved. And it can have three components: the government sector, the public sector, the private sector. The public sector must be responsive, and the private sector must be responsible, and perhaps there is a voluntary sector also. We really need to bring in all the three elements into the overall healthcare system. I am attracted to digital health because of what is really now happening in the information center and in the what we now call the data science. That information is a crux of the problem, and that information by itself provides a helping hand in terms of the curative procedures one will have to adopt. And this has been the way in which AI or generic AI or machine learning have now come to play an important part in the efficient functioning of the system must be noted, because that, after all, technology is not new to medicine or surgery. Technology has played and it continues to play a very big role in terms of the way in which the surgeries are done. People are now talking of robotic surgery and so on and so forth. Therefore, that aspect of medicine and surgery is well understood. And in fact, much of the progress that has happened in terms of the ability to cure also depends upon the technological progress that has happened. But that is one aspect. But when we talk of digital health, I understood, that's what I thought, that's what I read somewhere, namely that it is what the informatics can give. So the question of having what they call wearables and the continuous information which Dr. Shetty emphasized very much about where the information is stored and where the information can be tapped and how the availability of that information by itself plays an important part in the curative role. I'm sure that this is an area in which India as a country can make progress. But another thing on this AI and other things is basically what is happening to the development of knowledge itself. When we were studying and when we used to look at statistics, statistics was always regarded as an outcome of theory, or statistics is a tool to test the theory. The theory based upon experiments or based upon observations or many other things reaches certain conclusions. And then the role of statistics was considered to be that how, given the data or on tapping the available data, whether we can prove that theory is correct or not. Therefore, in some sense, causation came first. And data were used, or data are used after the formulation of theory to test whether the theory actually holds good or not. After the arrival of big data, we are moving to another stage. And that is because of the enormous data that are available and the data that can be processed through the computers, we can find patterns and correlations which can then lead to what can be done. Earlier, correlation followed causation. Now, what we are really talking about is correlation leads to causation. And that also requires how we use the statistical tools. I'm not very sure that a decade from now, we will use the same kind of statistical tools that we are now using. When we compute the correlation coefficient now, we look at a limited number of observations. On the basis of that observations, we say whether the theory holds good or not. But if you're looking at millions of observations, how that pattern itself will be derived will become something different. And that is where I want to tell people who really look at all of these observations, data science is distinct from statistics. Statistics, the way in which it works, will be very different, and data science will have to operate on a totally different thing. I'm not saying theory and causation are not important. They are very important. And I think the deductive logic on the basis of which many theories have been derived still becomes relevant. But the way in which the big data would be handled is something that we will have to learn a lot more in the coming period. Now that's a totally different thing, because I believe that the enormous amount of data that hospitals and other health centers they have can be utilized to reverse the process and see where that will lead to, and see whether that will lead to a theorization which holds the test of data. I will not go further into it. I mean, I think all that I want to say is that we had a very meaningful and useful evening. In fact, one advantage of what Dr. said this evening is really that when the insurer also becomes the provider of the services, and then the need to cut down costs, the need to reduce unnecessary transactions or unnecessary manipulations will also be greater on the hospital. And therefore that essentially combines two virtues in one institution. And that perhaps is also something about which we should note. Anyway, thank you very much, Dr. Dev-Prasad. We are all outsiders in the sense that we are patients, all right, but we don't know exactly what the medicine that does the trick. We really we are not in that field. But the point essentially is that the question of whether there is a conflict of interest between the hospital and the insurer, or on the other hand, the very fact that the burden is borne by the hospital or the burden is borne by the insurer makes him play the other role even more carefully and even more efficiently. I think it's probably people initially look at it as conflict of interest, but perhaps there is something deeper in it, and it is not really the conflict of interest. It may be the redoubling of the effort in order to improve efficiency in the system. Thank you very much, Doctor, and we enjoyed it greatly.
Thank you very much, Dr. Shetty. Thank you very much, Dr. Rangarajan. Thank you. It's always a gift to us when we listen to the wisdom that you bring along with you, you know. It's always a very rich source of knowledge. Yeah. I just wanted to call upon Dr. Vijay Lakshmi to present the vote of thanks. Meanwhile, we request Srimati Shobarani SSV to present the memento symbolically at this stage, later physically to you, Dr. Shetty. Thank you very much again on behalf of our institution.
Thank you. Thank you.
Thank you, ma'am.
Yeah. And there's another one to Professor Rangarajan. This is to our Chancellor, Dr. Rangarajan.
Just I'll take 2 minutes of yours. On behalf of ICFAI Foundation for Higher Education, I would like to extend my heartfelt thanks to the Chancellor, Dr. C. Rangarajan, for his constant and continuous support in conducting this event. Thank you so much, sir. We are highly indebted to Dr. Dev-Prasad Shetty, Chairman of Narayana Hridayalaya Limited, Bangalore, for accepting our invitation and delivering his speech and his valuable thoughts on transforming healthcare through digital health, which is very much relevant in current scenario. Thank you so much, sir. We are grateful to Srimati N. Shobarani Yashashvi, Chairperson, ICFAI Group, for her gracious presence. Thank you, ma'am. We are thankful to V.R. Shankara Garu, President, ICFAI Group, and Board of Governors of ICFAI Society for his continuous support. Of course, he must be watching online. Thank you, sir. I extend my wholehearted thanks to our Vice Chancellor, Professor L.S. Ganesh, for all his valuable suggestions. And also I extend my wholehearted thanks to Professor J. Mahendra Reddy Garu, former Vice Chancellor, IFHE, and distinguished advisor, ICFAI Society, for being a guiding support throughout. Thank you so much, sir. We are thankful to Dr. O.R.S. Rao Garu, Professor Bhanuji Rao Garu, and also Dr. Hargopal Reddy for their continuous support in conducting this event. Thank you so much, sirs. We are immensely grateful to all the distinguished members for attending the lecture in person and through online. Thank you all. I take this opportunity to thank all our directors, deans, heads of departments, esteemed colleagues, and support staff, and all the dear students for making this event a grand success. Our sincere thanks to Sudhakar Rao Garu, branding team, press and media for covering the event and for their continuing support. Thank you all. I wish to convey a special note of thanks to Director Administration and our entire administrative staff for making this event a grand success. Thank you one and all. And we request all of you to have refreshments waiting outside the auditorium. Thank you one and all. Good evening.
Okay, thank you, Dr. Shetty. I mean,
Thank you.
Thank you, sir. Thank you so much.
Thank you. Thank you, sir. Thank you.
Thank you very much, sir.
time at the when I come back.
Thank you. So nice.
Shetty, we are breaking for refreshments. We are sorry we can't attach refreshments and send via email.
Okay.
Thank you one and all.
Thank you, Dr. Vijayalakshmi. Thank you. Thank you. I'm seeing you first time after you are back from US.
Well wishes, I am back.
Okay. Welcome back. Yeah.
Thank you, sir.
Oh. Okay.
I took some time. Okay. Yeah, okay. All right.
Okay.
Okay, bye.
It's okay. You are. You say,